Wonderful. So we are ready. I hope so. Welcome our esteemed jury. Esteemed jury, dear participants, listeners, ladies and gentlemen, on the behalf of the Student Scientific Society of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in the International Medical Congress of Silesia 2023. My name is Maria Stec, and it's my great pleasure to coordinate the invasive cardiology and cardiothoracic surgery session. I would like to cordially welcome the esteemed jury of our session. Dr. Fabrizio Ascenzo from University Hospital of San Giovanni Battista from Turin.
It's a very honor for me to be here. Thanks, especially to Professor Voyaker for invitation, and also because this is a very important meeting, and it comes along with all the research that we do together, and the contribute of your university is very crucial for us. So for me, it's a big honor to be here, and we're very excited to see the abstract and the presentation that we will hold. Thank you very much.
Thank you so much, Professor. I would also like to welcome Professor Wojciech Wańcha.
Hello, everyone.
And Professor Beata Morawiec. Thank you for your presence and scientific custody of this session. And dear participants, before we start the first session, let me explain to you the principles and rules of the session. The order of the presentations will be the same as in the abstract book published before the conference. The maximum time for presentation is 7 minutes and 3 minutes for the discussion, and I will be in charge of watching your time. If the presenter exceeds the time of the prelection, he or she needs to move on to the conclusion and finish the presentation as soon as possible. Please remember that all presentations and the discussion must be run in English. And the jury will assess 5 aspects of each prelection: scientific value, way of presenting, as well as discussion and own contribution of the participants. And it should be 1 out of 5 points, as you can see on your forms. I hope they are working properly. Esteemed jury, when the session ends, we kindly ask you to send us the forms back to the coordinators. And I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number in your card or just simply do not insert your points here. These are all the regulations and rules we need to observe, but if something isn't clear, I'd be glad to answer your questions you might have. All right, so if we don't have any questions, I believe we can start our session now. So I would like to, all right, I'm back. Give me 1 second. Thus, we will start with the paper from the third Chair Clinic of the Invasive Cardiology and Electrocardiology in Katowice. And I would like to invite Marta Hamera, the shockwave intravascular lithotripsy as a new treatment method for underexpected stents.
Okay, so good morning, ladies and gentlemen. My name is Marta Hamera, and today I would like to present you our research about shockwave intravascular lithotripsy as a new treatment method for underexpanded stents. These days, percutaneous coronary intervention with stent implantation is more and more frequently performed and well-known treatment option for patients with significant coronary stenosis. There are now many factors contributing to PCI outcomes, with stent underexpansion as the strongest predictor of in-stent restenosis and stent thrombosis, which occurs in over 30% of ICR lesions. Despite of the use the well-established method in revascularization of calcified lesions, the stent underexpansion of the revascularization in stent underexpansion is still questionable. The efficacy and safety of intravascular lithotripsy have been confirmed in de novo calcified coronary lesions, but still little is known about its usefulness in treating stent underexpansion. Therefore, in this study, we aim to assess the safety and efficacy of intravascular lithotripsy in stent underexpansion due to heavy calcification. This registry is a multi-center observational study conducted. The data included 70 consecutive patients with stent underexpansion, which was defined as a relative stent expansion under 80%, and was evaluated by in-stent diameter stenosis as assessed by quantitative coronary angiography. Heavy calcification was defined as calcification within the lesion on both sides of the vessel assessed during the angiography. Patients were treated with intravascular lithotripsy between November 2019 and September 2022, either during the clinically indicated index PCI or were referred for planned IVL because of stent underexpansion detected during the previous procedure. The all angiographic and intracoronary imaging data were collected. The primary endpoint, which was used to assess the safety and efficacy in this study, was device success, defined as technical success with final percentage diameter stenosis under 20%. The secondary endpoint was device-oriented composite endpoint, DOCE, which was defined as a composite of cardiac death, target lesion revascularization, and target vessel myocardial infarction. By looking at the baseline characteristic, we can observe that the mean age of study population was 68 years and 66% were men. More than half of the presenting diagnosis was acute coronary syndrome, including most commonly non-ST segment elevation myocardial infarction. The most common diseases were hypertension and hyperlipidemia, and the mean left ventricular ejection fraction in this population was 48%. The median time since index PCA of target lesion was 12 months. Based on angiographic and procedural data, in more than half of the cases, the underexpanded stent was implanted within the segment with heavy calcification, and the most common vessel receiving IVL was right coronary artery. It was 50% of all cases. A non-compliant balloon was the most often used device for predilatation, 72.3%, as well as post-dilatation, almost 77%. Moreover, additional stenting was performed in about 22%. Even though no reflow was not observed during the PCI, one patient had perforation and other one had dissection during the procedure. The study's primary endpoint, device success, was achieved with 54 patients. During 30 days of follow-up, the incidence of secondary endpoint, DOCE, occurred in one patient and it was caused by cardiac death. In addition, at long-term follow-up, DOCE occurred in 3 patients, and each of cardiac death, target lesion revascularization, and target vessel myocardial infarction occurred in 2 patients. According to QCA findings, the minimum lumen diameter, MLD, increased from 1.1 to 2.6 millimeters, and the area of stenosis at this dimension decreased from 82.6 to 21.5%. The stent expansion assessed in OCT increased from 37.5 to 86%, and these all values were statistically significant. Here is a presentation of cumulative frequency distribution curves, which are demonstrate the stenosis of lumen diameter and lumen area at baseline and post-IVL PCI. And here we observe the decrease in both dimensions after IVL. And on this slide, there is an example of the effects using IVL to treat a stent underexpansion due to severe calcification. And on the left, we can see angiographic and OCT images of narrowing in the left anterior descending artery due to underexpanded stent. And on the right, the improvement in the area of stenosis and appropriate stent expansion after IVL. So to sum up, this registry of data referring to using intravascular lithotripsy to manage underexpanded stents due to heavy calcified lesions revealed the safety and efficacy in increasing lumen and stent dimensions. However, further prospective studies with long-term follow-up are required to confirm using IVL as an emerging first-line option to treat stent underexpansion. So that's all. Thank you for your attention, and if you have any question, I would like to answer.
Oh, thank you very much. I think it's very interesting. And my question is, what do you, apart from the abstract, what do you think is the impact of imaging in this patient? That is, do you use IVUS or OCT to select the kind of treatment for calcified lesion, or which is your approach? Thank you, and compliments again.
Terribly sorry, Dr. Dashchenko. Could you please repeat your question because somehow the technical problems stopped you?
Sorry. Compliments for your presentation. My question is, do you use imaging that is IVUS or OCT to choose the correct treatment for calcified lesion, or which is your approach? Because this is quite a debatable stuff in the cath lab. Thank you very much and compliments again.
I don't know if I will understand the question because with some problems, but these patients were chosen to this study. All patients had this quantitative coronary angiography assessment, but unfortunately the intracoronary imaging wasn't performed systematically in this study population. So probably in the future we want to continue this research to use intracoronary imaging in more number of patients.
Okay, thank you. Thank you very much.
Do we have any further questions? If not, thank you so much. Congratulations. And now we can invite Mrs. Daria Twardowska with the paper CHA2DS2VASc score and other risk factors, predictors of adequate ICD intervention, post-infarction patients. The floor is yours.
Okay, so I think we can start. Good morning, ladies and gentlemen. At the very beginning, I would like to present the criteria of ICD implantation from 2015 in primary and secondary prevention. However, our patients were qualified between 2000 and 2008. They were implanted according to the criteria of those years. So far, there have been many different studies that describe risk indicators of ICD intervention. For example, age above 70 years, diabetes, smoking, renal dysfunction, and many others. When it comes to the main aim of our study, it was to perform the analysis of the importance of potential risk factors in the population of patients after MI with ICD implanted. In our study, we considered the CHA2DS2VASc score and other parameters like dyskinesia, HR, SDRR. All of our patients have had previous myocardial infarction. So all of them had a point for vascular disease in CHA2DS2VASc score. On this slide, we'd like to present inclusion criteria for the study. And what follows are exclusion criteria from the study, which resulted in the creation of a sublime group of patients. So now we come to the next point, which is material and methods. The study was conducted using database of First Department of Cardiology. This database included prospective analysis of ICD implanted in primary or secondary prevention, and follow-up data based on clinical data and electrograms, which was obtained during ambulatory visits. The study population consisted of 155 patients with ICD followed up for at least 2 years. The end of observation was the occurrence of appropriate ICD intervention or the last ambulatory visit when no interventions were found. On this slide, you can see the sex and age distribution of our patient groups. You can see that group of secondary prevention was mass bigger than the primary prevention. And this graph illustrates the adequate ICD intervention was more common in secondary prevention patients. Now let's move on to the next chart, which presents distribution of CHA2DS2-VAS scores for primary and secondary prevention. We can see that points were similarly distributed for both groups. In our paper in this year, we analyzed data of patients of secondary prevention. Patients with CHA2DS2-VAS score above 1 had higher risk of ICD intervention. However, as we can see, there is no significant difference between patients with CHA2DS2-VAS score above 2 and 2 or less. The situation is similar in case of CHA2DS2-VAS score above 3. We can see the trend indicating lower risk of ICD intervention in this group of patients. Unfortunately, due to low number of patients in CHA2DS2-VAS score above 4, results cannot be considered meaningful. The explanation of why patients with more diseases had lower number of interventions may be caused by more frequent occurrence of heart failure. In our study, we used different sudden cardiac death risk factors. After analysis, we used dyskinesia, and you can see the difference in intervention of ICD. In case of patients with SDRR of 100 milliseconds or higher, the risk of intervention is significantly lower. And however, the results for HR above or equal 70 are not significant. So risk of ICD intervention in patients with different analyzed indicators, we can see hazard ratio is more than 1 for CHA2DS2-VAS score above 1, and the similar situation is for heart rate variability. All of this brings me to following conclusions. Higher CHA2DS2-VAS scores were found not to be associated with higher risk of the ICD interventions, but the presence of dyskinesia was associated with higher risk. SDRR above or equal 100 milliseconds was also associated with lower risk of endpoint occurrence. As you can see, making combination of different parameters like CHA2DS2-VAS score above 1 and SDRR may be very interesting. The preliminary study will be continued, other indicators will be analyzed, and the results will be presented in the future study. And for now, thank you for your attention.
Thank you for this wonderful presentation. Now we would be glad to start the discussion.
I would like to congratulate the study, it's very nice results. However, I have got the question, did you divide patients for the ICD with subcutaneous ICD or subcutaneous ICD and patients with leads ICD? Do you have those data? How many patients had SICD and how many patients had ICD with the lead in the heart?
I'm sorry, we don't understand so many problems here.
Right.
Please
Technical
repeat the
problems.
question because we couldn't hear you clearly. We'll solve the technical issues
So
in a second.
analyze the patients only with ICD, patients who had the ICD with the lead in the heart, or also you had data from the patients who had SICD?
No. Yeah, only ICD, primary and secondary prevention patients, implanted ICD.
All right, so only patients who had ICD with the lead in the heart, because there is also this one of the device who ICD without the leads in the heart, so it's called SICD. So probably you don't have those data, and you analyze the data with patients who had ICD or with the leads in the heart.
Only this ICD on the heart. Yes, exactly.
Okay.
This patient.
Okay, I think I want to compliment for the presentation. I hope that you hear me. But I think that you stated in the conclusion that the chest valve is not a predictor of events in this patient, but I think that probably is mainly a factor of sample size, because if you see the Kaplan-Meier survival tends to diverge with the prolongation of follow-up. So probably I think that if you perform the study with more patients, maybe you will find a significant value. So also because chest vascular basically embeds all the risk factors for recurrence. But again, compliment for the presentation.
Thank you very much.
Beata, do you have any questions?
Yes, I had some problems with microphone.
Now we can hear you clearly, Professor.
I keep this, but I wanted to ask what was the ratio of patients with primary and what was the ratio of patients with secondary prevention of sudden cardiac death in this group?
Primary prevention groups consisted of 30 patients, and secondary prevention group it was 125 patients. It was a huge disproportional.
Have you analyzed this factor as a risk factor for adverse events at the follow-up? If this was primary or the secondary prevention or not?
Could you repeat your question?
My question is, if you analyze this factor, I mean the secondary or the primary prevention as a factor for adverse events at follow-up.
We don't analyze it yet, but we could it in the future studies.
Okay, thank you.
Thank you.
Thank you for the presentation and thank you for such a heated discussion. Now I would like to invite the paper Aortic Valve Neocaspidization with glutaraldehyde-treated autologous pericardium, Ozaki procedure in Georgia, by Georgi Bokharia, Faculty of Medicine, Tbilisi State University, Georgia. Are you here with us? Oh, wonderful. Great to have you here. Did you see my mail? Yeah, I sent it and it should be there already. So. It's on. You should rub your device that helps you steer it in. It's next. Yeah, exactly. And here you see.
Okay. Good morning, ladies and gentlemen. It's a big honor for me to stand here. It's my first visit in Poland, Katowice. I'm from Georgia, the Republic of Georgia, and today I'd like to share you our little study for Ozaki procedure. It's in cardiac surgery, aortic valve neocaspidization with glutaraldehyde treated pericardium. My name is Georgi Bukaria. Start with the introduction. Aortic valve disease is one of the most common reason of death in nations with cardiac disorders. And for this, there are some type of treatments, like just interventional treatment. It's called the percutaneous treatment, or aortic valve replacement with biological or mechanical valve, and etc. But there are another way also to replace aortic valve, which is called Ozaki procedure, which has shown the promising outcomes in nations. What is it called, and who is Ozaki? Ozaki is a Japanese cardiac surgeon who implemented and established these types of procedure to replace patients' aortic valve. Today, this big question remains: which is better and the best option in patients? Just Ozaki, mechanical or biological valve, which is known for everyone in cardiology and cardiac surgery. In this case, we don't use mechanical or biological valve. Ozaki procedure means when we use patients' own pericardium to make new leaflets to suture and to make the new leaflets with patients' own pericardium. When we use this type of procedure, patients with nerve annulus, younger patients, not elderly patients, patients who don't want prosthesis, patients who cannot undergo any anticoagulation, future mothers, etc. Also, children with infective endocarditis and narrow annulus of the aorta, when we cannot suture in exactly small size artificial valve. Now I'd like to make a description step by step of this procedure. This procedure is done with median sternotomy. This is just traditional approach. After this, we are making the aortotomy, where we are making aortic annulus to size exactly the cusp size. After this, we are making the pericardiotomy, and after sizing of the sizing of the cusps, we are harvesting the pericardium. Just fibrous tissue is harvested from pericardium, and this patient's own tissue is already ready to cut off and to make new cusps. How these cusps are made? There are special equipment which is called sizers and special board, where each intercommissural length is measured, and after this, the midpoint of the channels is marked. After this, the pericardium is laid down in the special fluid called glutaraldehyde, about 10 minutes, and you see here the exactly sized harvested pericardium, non-coronary, coronary, and all of the cusps for aorta, which is the exactly natural size of the patient's annulus, and this pericardium is already ready to suture in and to create new natural well, not artificial, new natural well. And finally, you see here the cusps are already sutured in. And the suturing is started from the right coronary cusp, which is the most. The other side is we use about 4-0 polypropylene suture with a TF 3 millimeter. Suturing is always upside, from inside to outside. From inside to outside, it's always matter. And finally, the stage is refresh of the heart. Now I want to describe and just analyze all our data. The method, we retrospectively analyzed about 103 patients during last 7 years. Last 7 years, which we are making this procedure only in our clinic, is done in Georgia, and about 30 clinics in all over the world. Demographic data, patients 103. Perioperative echocardiography results, they had high gradient, and the ejection fraction was about 40 to 50, and also the calcification rate was too high in these patients. Pathology, it always matters in this case. Stenosis was about 68, regurgitation was 5, and stenoregurgitation was 30 from these final 100 patients. Type of aortic valve, tricuspid about 76, bicuspid aortic valve about 25, and unicuspid aortic valve 2. Types of surgical intervention, there was only AV neo about 64, and other operations were combined operation with other disorders. Postoperative data, it's always important to discuss, and why. Our mean gradient was improved and lowered. Hospital mortality was only 1 in these 103 cases. Mean follow-up in months was about 63 to 2, more or less 2, and also knee harm rates also was normalized, and patient's echocardiographic results was normalized. Results. On the behalf of our results, we can say that survival was about 85% during these 7 years in our clinic. For patients showed mild and moderate aortic insufficiency was 5 to 6%, and none of them showed severe aortic valve insufficiency. The Ozaki procedure creates just a good aortic valve with low stable gradient up to at least 17 years. But it's only our clinic's results. But as Shigeki Ozaki created these types of procedure in Japan, they have more than 15-year results, and the patients have none of complication during these 15 years old. There was some radio operation, there was some complication, but most of the cases were successful. And I would like to discuss what I wanted to show you, to present you, and why Ozaki and not artificial valves. The advantage of this procedure, patients doesn't need any anticoagulation, no gradient, no regurgitation, optimized cross-clamp time, which is so important in surgery, no clicking noise, and easy reprocedable operation, the best in patients with small aortic valve. Limitation, it's just need a longer ECC than a cross-clamp time in an AVR procedure, and also surgeon must be so experienced in complicated surgery. For non-tricuspid AV leaflets, the relatively complicated also is, and this has some types of complications like recalcification again, or something if patients has another furthermore infective disorders. And conclusion, we can say that on our clinic's database, this procedure should be just golden standard for future cardiac surgeries of the aortic valve surgery replacement. Even as a safe and effective method, it's also cheaper than other types of surgery of aortic valve. Even a low gradient is also a positive point in the recovery of stressed myocardium. And you know, in cardiac surgery is always the first point of myocardial protection. No necessity to use warfarin makes patient outcome and life easier, comfortable, and safer. Summary, an autologous pericardium should be gold standard, but we cannot say this today because still this procedure is considered as new, because 15 years not too much. Medicine needs about more than 20 or 25 years to implement, to establish something as a gold standard, and to say that it's the best option than AVR with biological or mechanical valve. But as I said, Ozaki procedure is good option in some type of patients. Patients with narrow annulus, childbearing ages, future mothers, and etc. Now, the final question is still remains, and I would like to ask you, what do you think, which is better by your mind and things? The Ozaki procedure is better, or biological or mechanical? Well, these types of procedure requires about 2 to 3 hours. Now, the pericardium is patient's own allograft. It is very hard to cause any immune response, any other complications. Recalcification is also low for this procedure, for this outcome after this operation. Ladies and gentlemen, that was all I wanted to share you our clinics database, and I think this procedure will be implemented and will be shared all over the world. Thank you for your attention. Peace in Ukraine, and I want to say again thank you to your ex-president Lech Kaczynski, who was between us in our country during our devastating days in August war when Russia attacked our country. And I'm refugee from my home, and he was one of the outstanding men who had a big role of stopping these 5 days bloody wars, bloody days in our country. Thank you for your attention.
Thank you very much for the presentation. I have only one comment that is, I think the most relevant point. One of the most relevant points of strength is that you know that you need a warfarin after this valve. I think this is very important in everyday clinical practice. My question related to this is: did you have or are there any reports about also late valve thrombosis or not in this kind of procedure? Thanks again and compliments.
Thank you so much for your good words. As I heard, you said that this good point that we don't use warfarin, but I couldn't figure out what was the main idea of your question. Could you revise it, please, sir?
Yeah, sorry. My question is that you stated that you don't need warfarin or Coumadin after this valve, but reflecting about also the type of procedures, sometimes we experience very late thrombosis or valve failure, probably related to microthrombosis of the valve. Did you have any experience about this in your population or not? Thank you again.
Okay, after Ozaki procedure, as you asked?
Sorry?
After our Ozaki procedure? Yes, there was no thrombosis. Patients had just 3 months anticoagulation with hemoxyparine. It's just low molecular anticoagulant, and we just used subcutaneous injections, and patients didn't require any anticoagulation, and there was no case of thrombosis after this procedure, if I correctly understand your question.
Yes, perfect. Thank you.
Thank you.
I would like to congratulate the study and all of your team. And I have got the question. In some patients, you report that some patients had reoperation during the follow-up.
Yes.
Yeah? And what kind of the treatment, what kind of reoperation it was? It was again the same operation, or it was the standard treatment of the IVR?
Okay, thank you for your question, sir. On these types of reoperation was patients was complicated with ascending aortic aneurysm after this procedure, and one of the cases was also the patients with the recalcified new cusps of this exactly own pericardium. It was after 5 years in one patient, as I remember, and one more also was more than 7 years, but I don't know the this case exactly because in this time of period I wasn't medical student, and as I know, there was only 3 radio operation. 2 was complicated with aortic aneurysm, and one of them was recalcification of the new cusps we used.
Very nice work.
Thank you.
Thank you so much. Do we have more questions from Professor Sierniała, from Professor Morawiec? Thank you so much for this interesting cardiothoracic surgical point of view.
Appreciate it.
Did great work. Thank you so much. And now I'd like to welcome Mr. Wojciech Olejek with the paper Avoiding Injury During Catheter Radiofrequency Ablation, Anatomical Implications from the Department of Cardiovascular Surgery and Transplantology of the Jagiellonian University Medical College. The floor is yours.
Dear jury, dear audience, my name is Wojciech Olejek, and I'm pleased to present to you our recent study made by Karol, Cardiothoracic Anatomy Operative Lab. The background of the study was that the mitral isthmus, which is a structure in the lateral posterior inferior wall of the left atrium, is a often used place for radiofrequency ablation in treatment of atrial arrhythmias. And the close proximity of coronary arteries, especially circumflex artery, can be a possible cause of complications after this procedure. So the description of the anatomical localization of those arteries appears to be crucial for the outcome of the procedure. The ablation is a procedure, especially this mitral isthmus procedure. Isthmus ablation is performed by creating scar tissue in order to stop re-entry circuits that would cause the atrial arrhythmias. So the aim of the study was to evaluate the proximity of the circumflex artery and left coronary artery itself to the mitral isthmus in order to assess the risks and possible complications of the mitral isthmus ablation. Materials: we studied 105 angio CT scans. The heart itself and structures surrounding the heart were segmented and visualized in 3D visualized, and on this visualization, the location of circumflex artery was evaluated. We also set points on the mitral annulus in order to seek for the location of the bifurcation of the left coronary arteries. And as you can see in this picture, there are three parts of the posterior part of the mitral annulus, and each of these parts we divided then into 4 zones, and based on that we assessed the localization of the bifurcation of the left coronary artery. Results we got. The localization of the circumflex artery in 27.6% was within the mitral isthmus. To be clear on that, the mitral localization within the mitral isthmus could also be called localization superiorly to the coronary sulcus. So basically on the left atrium wall. Coronary localization within coronary sulcus itself, it was 54.3%, and inferiorly to the coronary sulcus, 18.1%. We also assessed, as I said, localization of the bifurcation of the left coronary artery, and the most common localization of the bifurcation was just between the P1 and P2 parts of the mitral annulus. So, concluding, the well-known anatomy of the circumflex artery appears to be insufficient in order to assess the possible risks for each individual patient during mitral isthmus ablation. As it was stated, over 25% of the cases we studied had the circumflex artery above the coronary sulcus, so it was in close proximity of a left atrium wall, which is far less thinner and can be a zone of danger for the circumflex artery. As well as the bifurcation of the left coronary artery itself appeared to be in close correlation with the mitral annulus and mitral isthmus. So the damage, the potential damage that could be done by the radiofrequency ablation could be inflicted either on the circumflex artery or the left coronary artery itself, which could be fatal for the patient. So how do we use this data? We suggest performing the CT scans before the ablation in order to assess the individual anatomy of the coronary arteries, to maybe somehow reevaluate the decision of making the particular decision about the mitral isthmus ablation, and maybe to choose the other possible ways of treatment for the atrial arrhythmias. Thank you for your attention.
Thank you for the presentation. Do we have any questions from our scientific jury?
Compliments, I have no particular questions. Compliments again.
Thank you.
I would like to congratulate such nice study. According to your information and your data from your center, could you tell me how many patients had injury of the circumflex during those procedures? Do you have such data?
We did not collect such data. As far as I'm concerned, I found that asymptomatic constriction of the circumflex artery could exist in over half of those patients, but that's the asymptomatic constriction. We did not collect the data about the arrhythmia, about the ablation, mainly due to the fact that those scans, those were just patients in our clinic, not those patients who underwent the ablation.
All right, congratulations, thank you.
Thank you so much. Congratulations once again. Thank you. And now We're staying at the Department of Cardiovascular Surgery and Transplantology of the Jagiellonian University Medical College. And now I would like to invite Mr. Michał Piotrowski with the paper Is Anatomical Predisposition for Coronary Artery Injury During a Tricuspid Valve Repair Sex-Related? The floor is yours.
Ladies and gentlemen, honorable jury board, my name is Michał Piotrowski and I have a pleasure to present you the results of our work concerning the factors which have impact on the iatrogenic damage of right coronary artery during the tricuspid valve interventions. How to switch the slide? Oh, I see. Sorry. Yeah, okay. Exactly. One more, because I need to. Okay, I think it works now. At the beginning, I would like to mention that 1 in 10 of the patients in the elderly population have a tricuspid regurgitation. The tricuspid annuloplasty is the surgical treatment for such disease. Unfortunately, the tricuspid annuloplasty has a really high mortality. There is minimally invasive approach which can be used to minimize the mortality. Despite this is pretty new method, and there is not enough data to for sure say it is really the best option to lower the mortality. One of the factors which have a huge impact on the right coronary artery damage and high mortality of the tricuspid annuloplasty is specific anatomy of this region. As you can see in the figure right there in the slide, the close relations between tricuspid annulus and the right coronary artery, especially in the distal part, might be one of the factors which indicates that the iatrogenic right coronary artery damage can happen. It's worth mentioning that there is only one first-class indication for tricuspid annuloplasty. It is when you do left side heart surgery at the same time, and all other indications are second class. The mentioned factors, especially specific anatomy and lack of data about operative topography of tricuspid annuloplasty, was the reasons why we decided to investigate the specific anatomy of this region, and it was the aim of our study. Also, we aimed to find whether the sex has impact or other factors has impact on the anatomical predisposition for iatrogenic right coronary occlusion. There is demographic data of our population. We had 116 scans, CTA scans of patients before atrial fibrillation. And we excluded 9 of them after close examination because of the poor quality of CTA scans which we had. The demography of the population is visible in table right there. At the beginning, we prepared the 3D CTA visualizations, as you can see on the slide, with the semi-automatic algorithm mimics innovative suite, which is FDA approved for clinical use. So all measurements conducted in the 3-dimensional planes were accurate in the clinical perspective. We prepared the models of right coronary artery and tricuspid annulus and all surrounding structures. And we conducted all measurements in 3-dimensional planes. We measured tricuspid parameters like short and long diameter, area of tricuspid annulus, and perimeter of the tricuspid annulus. Then we divided the tricuspid annulus perimeter into septal part, where septal valve leaflet incisions are present, and also the second free wall part, which we divided into 12 zones, 12 equal zones, and we conducted all measurements between right coronary artery and tricuspid annulus in each point. The research showed that the tricuspid parameters were significantly higher in the male population. It's probably due to the bigger size, to bigger average size of heart of the male. And all results were statistically significant. The p-value is visible in the table right there. On the other hand, the distances between right coronary artery and tricuspid valve annulus were not statistically significant almost in all measured zones, all 12 measured zones, despite the third zone. Presumably, the difference between males and females in this zone was caused by the specific shape of the tricuspid valve annulus and the changes in the vertical distances. All the other zones, on the other hand, differences between males and females were not statistically significant, and perhaps both sexes are equally predisposed to this fatal right coronary artery damage. We also found that in the distal portion of right coronary artery, the distances are the lowest. The 9th and 10th zones were the danger zones, where the closest distances were present. And also, after a review of the literature, we found 12 cases of right coronary artery damage, and all of them were present in the distal portion of right coronary artery, corresponding with our anatomical findings. It's also worth mentioning there were only 12 reported cases to this day, despite the 4 cases were reported in only one clinical center. And perhaps the right coronary artery damage is underdiagnosed condition. It's also worth mentioning at the end that the reported cases have similar both sexes were equally represented in the reported cases, corresponding with findings of our study. At the end, I would like to mention that the CTA 3D segmented scans are accurate in the preoperational imaging of. Excuse me, what? Oh, okay, sorry. So I would like to mention that 3D segmented models are might be the great tool for preoperative planning, and iatrogenic right coronary occlusion during the tricuspid annuloplasty is the thing that should be considered during the planning of such procedure. Thank you for your attention.
Thank you for the presentation. Do we have any questions from our jury members?
I would like to congratulate the study. I don't have any question, but in my opinion, it's a very important study and very important diagnostic to do it before such procedure. I remember one patient who had circumflex occlusion after those procedures, and it was a horrible situation for me. Thank you, and congratulations.
Thank you, Professor.
Also, from my point of view, I think this is very important also because I think the integration with CT scan is the future, both for TAVI, for CLIP, and also for surgery. So I think it's a very important and very relevant study. Thanks you very much.
Thank you very much.
Thank you for these comments.
I'd like to congratulate you on this topic, and one question for me is actually to maybe stress the value of your work. It's just to ensure myself in this, if all those technical issues regarding the programming and the construction and the software for CT scans was made by yourself, or you used some help from technicians or radiologists?
Sorry, because there was some technical issues, but if I understand correctly, you were asking if we had any technicians in the study helping us in the 3D segmentation, or because there was some technical issue and I haven't heard.
More or less.
Okay, at the beginning of the work of our research lab, we are preparing the techniques to the 3D segmentation with the help of radiologists. But right now, this study was conducted without any help, only with the help of our tutors, the professor of cardiosurgery, which also have the experience in such 3D visualizations, and they're checking if we are doing everything correctly.
Okay, but again, congratulations and good luck.
Thank you very much.
Thank you for the discussion. Congratulations once again. I believe now we can proceed to the next paper. Mrs. Emilia Kupczyk and the paper Quality of Life in Patients with Leadless versus Transvenous Pacemaker. The floor is yours.
Dear jury, dear audience, my name is Emilia Kupczyk, and today I would like to present a work about quality of life in patients with a leadless versus transvenous pacemaker. In Poland, we have 30,000 stimulators implanted every year and about 500,000 of patients with already implanted device. That makes a large group of patients that needs our special attention and care, and also it makes a place for scientists to observe, analyze, and solve potential problems of that patients. Here we can see the difference between the traditional transvenous pacemaker and the leadless pacemaker. The leadless pacemaker is an answer for many complications related with the transvenous pacemaker. As you can see, it's placed in the right ventricle of the heart, and it's connected with less of complications such as infection of the pacemaker. The implantation procedure is done in the cath laboratory. The access is a femoral vein, and we insert the device through using micra special delivery system. And the whole procedure is controlled by contrast and X-ray. Because the leadless pacemaker is a novel device that was accepted by FDA just in 2016, we wanted to check and compare the group of patients with leadless pacemaker and transvenous pacemaker, and we wanted to check the quality of life in both groups. So we have chosen 31 patients with a leadless pacemaker, and we matched for them patients with transvenous pacemaker by gender, age, and indications for implanting the device. As there is no specific questionnaire for quality of life at patients with pacemakers, we have used two popular ones. First one was 36-item short-form health survey, and the second one was Minnesota Living with Heart Failure questionnaire. Both questionnaires included mental and physical state condition of the patients. Here we can see the baseline characteristics and the New York Heart Association left ventricular ejection fraction and myocardial infarction, and as well atrial fibrillation, does not significantly statistically differ between the groups. Also, the comorbidities such as coronary heart disease, diabetes, chronic kidney disease, arterial hypertension did not differ significantly between the groups. And as well, the medications at discharge did not show significant differences between the groups. The indications for pacemaker implantation were the most of the patients had an atrioventricular block second or third degree. The second place was, with numbers, was atrial fibrillation with symptomatic bradycardia. And the two last ones were sinus node dysfunction and a syncope. Here we can see some of the procedure characteristics. As you can see, the procedure time were longer at leadless pacemaker. Fluoroscopy time were longer at also leadless pacemaker, and also the radiation dose were higher in this group. The patients who had leadless pacemaker implanted were staying longer at the hospital with median of 7 days. And also in this group, most of the patients were undergoing general anesthesia, while in the transvenous pacemaker group, that was mostly regional anesthesia. Here we can see the results of the patients' answers for the questionnaires. As you can see, there was a median of 33.5 points in the LPM group for Minnesota Living questionnaire and 21 points for the transvenous pacemaker group. The higher the score is in this questionnaire, the result of the scores, the worse condition of the patient is. Now moving on to a 36-item short questionnaire. The median score for LPM group was 16.5 and 54 points for LPM group and 35 median points for PM group. So as you can see, the results showed that there were no significant differences between total points and also subgroups such as mental, physical condition. So our result, the study showed that quality of life after device implantation does not differ significantly between a group of patients with leadless and conventional pacemaker. We have observed a few complications. However, the complications at LPM group were less serious than in transvenous pacemaker group, where even there was a need to re-intervention due to dislocation of the right ventricular lead. And also there was an infective endocarditis occurred. We have observed 10 deaths in LPM group during days of follow-up and 7 deaths in PM group. So once again, the conclusion of this study is that quality of life after the device implantation does not differ significantly between both groups. Thank you very much.
Do you think that this reflects a kind of learning curve, or which is your explanation about this? Thank you.
Sorry, could you please repeat the question because there was a little, just a little bit louder, please.
Sorry, it's my fault. Sorry for reporting your experience there. I noticed the longer time of implantation and the higher radiation exposure in transvenous leadless pacemaker implantation. Do you think that this reflects a learning curve or what else? Thank you.
First of all, the technique of implanting leadless pacemaker is a bit different technique than a transvenous pacemaker implantation. That's why also the time is longer because of the experience of the operators, and also just the time of radiation dose is related. It's higher due to just the different technique of the procedure. If I correctly understood your question, sorry. Any more questions?
I have got one question. What kind of indication, most indication for leadless pacemaker had patients? It was atrial fibrillation, AV block, but all of those patients had atrial fibrillation or not?
No. If we can I go back to the how to do this? Most of the patients had. Oh, sorry, I can't see the presentation. However, yes.
For one lead implantation is atrial fibrillation.
Yes, atrial fibrillation with a slow ventricular response.
Yes, and all of those patients had atrial fibrillation or implanted leadless pacemaker in patients with sinus rhythm. With patients who had sinus rhythm, normal rhythm, had BVI pacemaker implanted.
One second, just.
I have got the question. How many patients in leadless pacemaker had atrial fibrillation?
At the moment, I don't I would have to see the numbers. Like I can't answer the question straight away because I can't see the numbers in front of me. Sorry, but I just don't have that much good memory to answer it straight away. I mean, and I really don't have the access. Like I can't switch to the presentation now to check. Right. I'm sorry about that.
No, thank you.
Thank you.
I want to ask first, congratulate you on this, and to ask about two things. First, if you analyze the questionnaires, the quality of life in patients that had the device implanted some time ago, and you just updated the data for the quality of life, the first one, and the second one, if you considered to assess this quality of life retrospectively from the point from before implantation of the device, and to compare to the one that you assessed 6 months after. Thank you.
Sorry. So the first question was if we have the patients with. Sorry, could you please repeat the first one?
If you, the first one was about the chronology of doing things. I mean, if you first picked up from the database all patients that had the device implanted and then called them up and analyzed the quality of life after 6 months in follow-up, or you just enrolled them prospectively and followed up for 6 months and then assessed the quality of life. The first one. The second one, if you assess the quality of life before the implantation procedure and compared, or were thinking about comparing with the one after 6 months.
So the first one. So the first question answer is that we first implanted the device, and then after 12 months we checked with the questionnaires the answers for the patients, and our aim was to match the patients with PM and LP and transvenous leadless pacemaker and transvenous pacemaker, so they are as close to each other as we can, so we can exclude other factors and see if really the quality of life is connected with the device, not other things. And sorry, if you could once again repeat the last question.
Okay, I think it's enough. Thank you very much.
Thank you so much, sorry.
Thank you.
I'll take care of it. Thank you for the discussion. And now I invite Mrs. Magdalena Balwierz with the paper Influence of Atrial Fibrillation Risk Factors and their Modification on RePVI Efficacy.
Good morning, ladies and gentlemen. My name is Magdalena Balwierz and I'm representing Medical University of Silesia in Katowice. Today, I have a great pleasure to present the results of a single-center study titled Influence of Atrial Fibrillation Risk Factors and their Modification on RePVI Efficacy. Pulmonary veins isolation as one of the most effective methods of atrial fibrillation treatment is a percutaneous catheter ablation in which arrhythmogenic foci in pulmonary veins are being eliminated using radiofrequency waves or sub-zero temperatures. However, atrial fibrillation risk factors may have an impact on the success of the procedure. Recurrence of atrial fibrillation may be an indication for RePVI. In 2020, European Society of Cardiology published new guidelines for the diagnosis and management of atrial fibrillation, which proposed new integrated management for atrial fibrillation. It was ABC pathway. It includes anticoagulation, better symptoms management, and cardiovascular risk factors and comorbidity optimization. The aim of our study was to evaluate the influence of atrial fibrillation risk factors and their modification on RePVI efficacy. A single-center study was performed at the First Department of Cardiology of Professor Leszek Giec Upper Silesian Medical Center in Katowice. The observation period was from 2017 to 2022. 1736 PVIs were performed during this time because of atrial fibrillation, and 75 of them were RePVIs. Study inclusion criteria were as follows: recurrence of atrial fibrillation after the first PVI, undergoing PVI and RePVI, and possibility of collecting follow-up data. 75 patients underwent PVI and RePVI. There were 36 males and 39 females. Mean age at the first PVI was about 57 years. Patients were analyzed at the baseline at PVI and after the follow-up period at RePVI, and mean time between ablations was 26 months. Analyzed parameters included gender, age, time between ablations, comorbidities, BMI, smoking, laboratory test results, pharmacotherapy, ECG parameters, echocardiographic parameters. Follow-up data revealing atrial fibrillation recurrence after RePVI was obtained from 43 patients, and this study group was divided according to the efficacy of RePVI into successful and unsuccessful RePVI subgroups. Recurrence of atrial fibrillation was observed in 30 patients. It was almost 70%. In both subgroups, patients underwent the first PVI at the mean age of 56 years and RePVI at the mean age of 58 years. Mean time to atrial fibrillation recurrence after RePVI was 9.5 months, while the mean time of observation of successful RePVI subgroup was almost 19 months till the end of the observation without atrial fibrillation recurrence. Echocardiographic parameters didn't differ significantly between each other, between subgroups, neither at PVI nor at RePVI, and they also didn't change significantly during the time between ablations. Unsuccessful subgroup presented higher prevalence of patients with BMI over 30 kilograms per square meter than successful subgroup at PVI, but lower at RePVI. 25% of patients in each subgroup, patients who had BMI over 30 kilograms per square meter, reduced their BMI below 30 kilograms per square meter. The incidence of arterial hypertension was similar in both subgroups at PVI and at RePVI, and it was oscillating around 70%. However, this incidence increased in the time between ablations, but successful subgroup showed greater amount of well-controlled arterial hypertension patients at PVI than unsuccessful subgroup. It was 78% versus 55%, and at RePVI 90% versus 68%. In both subgroups, about 50% of uncontrolled arterial hypertension patients improved the control of their blood pressure. The incidence of hyperlipidemia was lower in unsuccessful study group. However, the amount of well-controlled hyperlipidemia patients were greater in also unsuccessful subgroup, as well as the improvement of lipid panel parameters. Similar results were gained for the diabetes. However, none of the patients from both groups improved the control of their glycemia. This study had some severe limitations. First of all, there was a small study group. What is more, a small amount of patients reduced their risk factors. And finally, there was not only the tendency to reduce risk factors, but also to worsen patients' parameters. To conclude, improvement of atrial fibrillation risk factors is a rare phenomenon after an unsuccessful PVI. And what is more, modification of atrial fibrillation risk factors does not seem to be better protection from atrial fibrillation recurrence after RePVI than their baseline control. Thank you for your attention. If you have any questions, please don't hesitate to ask them.
Thank you for the presentation. Do we have any questions from our scientific jury?
Congratulations on this work. It gives some insights, detailed insights into the risk factors of the recurrence. And my question is, maybe I skipped this. What was the definition of successful or unsuccessful, the time definition, ablation?
Thank you for this question. So, unsuccessful RePVI was defined as atrial fibrillation recurrence. So, we mean we gained ECG of 30 seconds of atrial fibrillation. Some patients had 24-hour Holter monitoring. Some patients had a single ECG at periodical clinical visits, and some patients had this early recurrence even during this hospitalization at RePVI.
Okay, but how long have you been observing patients after the procedure to say if it's successful or unsuccessful?
We were observing them till the recurrence or till the end of the observation period, till the end of 2022.
22, okay. Thank you.
Thank you for this comment. Do we have any questions from Professor Daszczenko or Professor Wajcha?
I would like to congratulate, and I don't have any comments for the comments. Very nice work.
Thank you.
Thank you so much for your presentation. Congratulations. Yeah, I'll grab. And now I would like to invite Natalia Nawrat with the paper Intravascular Lithotripsy and Rotational Arterectomy for Treatment of Broad Spectrum of Coronary Artery Diseases.
Good morning. My name is Anna Byra, and together with my colleagues, I would like to present to you our work, which topic touches on the issue of intravascular lithotripsy and rotational atherectomy for treatment of broad spectrum of coronary artery disease. Strongly calcified stenosis in coronary arteries remain a major challenge for present intravascular cardiology. They are associated with a higher incidence of serious cardiovascular events in the general population. And the aim of our study was to compare patients subject to IVL and rotablation and evaluate the procedural efficacy of both techniques of coronary debulking. And throughout my presentation, I would like to tell you about the background of our study, our materials and methods, results, and at the end, the conclusion. So intravascular lithotripsy using a shockwave balloon represents a new method of treatment of heavily calcified coronary lesions, paving way for successful stent expansion, and rotational atherectomy represents an old and established technique. Now let me compare the two methods. Although they are both minimally invasive procedures, there are some differences between them. And what is IVL? IVL is a method that uses a small catheter with a specialized balloon at the end, and the balloon delivers sonic pressure waves to break up or crush the calcified plaque to restore the blood flow. And on the other hand, rotablation uses a small diamond-tipped drill called rotablator, which rotates at the high speed to guide away at the plaque buildup and help restore the blood flow. Our study was a retrospective case control study from a single reference cardiology care center. The study compared patients with acute and chronic coronary syndromes in terms of baseline, procedural characteristics, and treatment effects. Our study included 30 patients hospitalized from June 2017 to January 2023. Our study group was 18 patients after IVL, and our control group, it was 12 patients after rotablation. And our primary endpoint was procedural success. Now moving on to analyzed factors. When analyzing history of our patients, we took into account such factors as age, sex, BMI, primary diagnosis of our patients, including ST elevation myocardial infarction, non-ST elevator myocardial infarction, stable and unstable angina pectoris. Our patients' chronic and past diseases, for example, hypertension, hyperlipidemia, obesity, diabetes. If the patient had any cancer past, if the patient is smoking, the medication test, the medications taken. If the patient had STMI, NSTMI, stroke, or stenosis. Also, we took into account echocardiography results, such as heart rhythm, heart rate, ST elevation, ST depression, and inverted T waves. Also, what was the access to the vessels, if it was femoral, radial, or brachial, and also the complications of the procedure. Patients subject to IVL were younger. They had similar age and primary diagnosis distribution. They had a comparable left ventricular ejection fraction and peak of troponin levels. IVL patients had greater prevalence of peripheral artery diseases and shorter time of procedure. IVL patients also required smaller number of stents, and less frequently IVL was performed via femoral approach. And here are some comparison of diagnosis on admission. And both treatment modalities led to 100% success rate with no in-hospital mortality and a trend towards higher rate of femoral hematoma in case of rotablation. Although both methods were 100% effective, the IVL is related with less extensive revascularization and a shorter procedural time. It required less preparation, and in most cases, it could be performed in less than 90 minutes. The choice of which technique to use depends on the patient's specific needs, the location of dilation, and the severity of it. And thank you for your attention.
Thank you for the presentation. Do we have any questions from our scientific jury? So what was your personal input into the paper itself? That's maybe the first question from me. Have you collected the data, or what have you done in terms of the study?
We went throughout the data and we analyzed the history of hospitalization of the patients and their diseases, the other factors, and then we took some conclusions out of it.
All right, thank you. Professor Marvis, do we have any question from you?
I have got one question. How often did you use the intravascular imaging, and was it a problem during those procedures? And how many patients did you have under expanded stent? Do you have such data?
And maybe you could repeat the question?
And how many patients did you use intravascular imaging? OCT or IVUS? Okay.
Anyway, congratulations, girls.
Thank you. So maybe we should proceed to the next presentation with Kamil Florek from Institute of Heart Diseases, Wrocław Medical University, comparison of two techniques for the treatment of calcified coronary artery lesions. The floor is yours. Oh, no, Kamil Florek. Wszystko czeka. Nie powinno być problemu.
So, ladies and gentlemen, I'm really grateful that I have an opportunity to present you the work entitled Comparison of Two Techniques for the Treatment of Calcified Coronary Artery Lesions. In other words, rotational versus orbital thoracotomy in hospital comparison. My name is Kamila Florek, and I'm representing the Invasive Cardiology Student Scientific Group from the Institute of Heart Diseases in Wrocław Medical University Hospital. So the plan of my presentation is as follows. And proceeding to the background, rotational and orbital thoracotomy are highly effective in modifying severely calcified coronary artery lesions. Both techniques use rapidly rotating burr. However, there are many differences between those two techniques. And the main difference is the fact that with orbital thoracotomy, we are able to ablate forward and backward, what is impossible with rotational thoracotomy, what may cause, for example, the bar entrapment. Although rotational thoracotomy is better tool in tight stenosis, both techniques are dependent of the lumen size, and with similar effectiveness they target calcium selectively. However, orbital atherectomy at some point is able to modify deep calcium as well. And moreover, with orbital atherectomy, temporal vessel occlusion is not present. As well, other studies have noted that significant differences in no-slow flow phenomenon occurrence are between those two techniques, what is supposed to be associated with the size of debris produced during the procedure, which is 2 micrometers in orbital atherectomy, compared to 10 to 15 micrometers in case of rotational atherectomy, what obviously makes a difference as the mean microcapillaris diameter is 8 micrometers, so the distal embolization is more possible in rotational atherectomy. As well, the cocktail with verapamil, nitrate, and heparin as a flash is not needed in orbital atherectomy, in contrast to rotational atherectomy. So here you can see the devices used in both atherectomies. Here is rotational atherectomy burr, and here microcrown and classic crown used in orbital atherectomy. And as rotational atherectomy was used for the first time in 1980s and in Poland in 2008, orbital atherectomy is considered as a novel technique because its first time human use was in 2014 and in Poland in 2021. As well, currently in Poland, just a few centers perform procedures using orbital atherectomy. So the aim of our study was to compare the older technique, which is rotational atherectomy, and novel orbital atherectomy according to patient's clinical profile, procedural and angiographic characteristics, and as well we compared the periprocedural complications. To obtain the data, we revised 125 procedures from our high-volume center. The treatment, of course, was performed by experienced operators and was consistent with current standards. The procedure success was defined as a successful stent delivery with no major complications defined as perforation, no flow or tamponade. We compared the outcomes of 100 rotational atherectomy procedures from our center first 5 years of that technique usage with 25 first consecutive procedures of orbital atherectomy. We decide to compare the early stages of the learning curve in case of both techniques to minimize the bias driven by operators' experience according to that technique's atherectomy's performance. According to patients' clinical characteristics, it's a busy slide, but I would like to conclude that in rotational atherectomy group, Euro score was significantly higher. However, from the insight of stratification, it's still the low risk in both groups. As well, in rotational atherectomy groups, patients more often had prior PCI and were present with acute coronary syndrome. Although orbital atherectomy patients more frequently had hypertension, hypercholesterolemia, and as well dialysis. In contrast, according to procedural characteristics, in orbital atherectomy, there was noted higher number of implanted stents, as well higher total stent length. The procedures were longer, more frequently left anterior descending artery was modified. However, there is a significant difference in contrast volume and rotational and radiation dose in orbital atherectomy compared to rotational atherectomy. Importantly, There were no significant differences according to peri-procedural complications and as well procedural success between those two groups. And what I want you to remember from that study is the fact that rotational and orbital atherectomy revealed comparable success and similar safety. Hence, in decision-making process, we should apply tailor-made approach, taking into account the patient's coronary artery anatomy and as well operator's experience, and the decisions should be made as well consistent with current knowledge. Furthermore, lower radiation doses and contrast used in orbital atherectomy group should be considered as well in according to longer follow-up outcomes, because it may lower, for example, the contrast-induced nephropathy, and that associations should be evaluated in further studies. Thank you for your attention.
I would like to congratulate such interesting study. Your center has a very high experience in orbital atherectomy and rotational atherectomy. And I have got a question: what do you think about the time of the longer procedure in orbital atherectomy? It's learning curve or other situation in your clinical practice? How do you think?
Excuse me, if you would be able to repeat the question, because the connection was interrupted, and I would be grateful.
All right. I have a question. How do you feel that orbital atherectomy, it is the longer procedure than rotablation atherectomy?
So what's the reason of that the difference? So according to the data which we found in the PubMed, there are like recommendation, no indication or guidelines, recommendation to perform orbital atherectomy in 30 and 25-second passage, and so that waiting time after that passage should be longer than that performed one, because of the heat which is produced during the procedure. So that's the difference, I think. From my point of view, it's really important.
Very good question. It means that you understand those procedures. Thank you.
Thank you.
It is the reason why.
Thank you. Also from my side, compliments for your experience. And my question is, did you use imaging? I think it is also similar to another similar answer presented on calcified lesion, but my question is, what is the impact of imaging or calcified lesion, and did you use also imaging to choose your kind of technique? Thank you very much.
So I'm the second author. I will try to answer this question. Speaking after such a good presentation is like singing after Caruso, but I will do my best to respond to your question. Yes, of course, we use IVUS and OCT as well. IVUS have been used in 60% of patients, and OCT have been used in 20% of patients. It is very helpful technique in comparing these two methods, because the calcium concentration which we can image with these two techniques can different the indications for these two procedures. So in some patients, the image from IVUS or from OCT were crucial in deciding which technique will be used in each patient.
Yes, so if it was more superficial, rotational atherectomy was implemented, and if the lesions are more eccentric, it's better to use orbital atherectomy because of its mechanism of action.
And stent location in the treated area was the contraindication for those two procedures?
Could you repeat one more time? If I understood it well, did you ask about the using such methods in stent restenosis or? Yes, it is contraindicated, especially in orbital atherectomy, but I found one clinical trial when they were trying to use rotablation in stent restenosis, and there were some results that may suggest it will be possible in the future, but as I know from our clinical experience, for now it's contraindicated.
Right now we have the third device, so we have the intravascular lithotripsy, so I think...
So it's more appropriate to do it this way.
I think that in patients with stent under expansion, the third method, so intravascular lithotripsy is the best option. However, in patients without stent implantation before in the target lesion, those two procedures such atherectomy or rotablation are very helpful for treating calcified and underexpanded lesion for the after balloon high pressure balloon PCI. So congratulations.
Thank you.
Congratulations
for me as well for the understanding of the topic.
Thank you so much.
Congratulations for this thorough discussion and a very emotional presentation. It was amazing to see you. And now, Michał Kapałka from the Department of Congenital Heart Defects and Pediatric Cardiology with the presentation on results of transcatheter closure of patient ductus arteriosus in neonates and infants less than 6 kilograms. The floor is yours.
Dear committee, dear chairman, my dear colleagues, my name is Michał Kapałka. I'm representing Department of Congenital Heart Defects and Pediatric Cardiology from Faculty of Medical Sciences in Zabrze, and I'm honored to present results of transcatheter closure of patent ductus arteriosus in neonates and infants less than 6 kilograms. And at the beginning, I want to show why this group is special and why we took especially those patients under the considerations. Patent ductus arteriosus has 6 different types and 5 different sizes. Interventionists should consider multiple anatomical variants to choose the best device for the patient. And due to devices, we have 3 devices. Each of them has its own contraindications. Duct occluder 1 and duct occluder 2, those are contraindicated in patients weighing less than 6 kilograms. So exactly in this group we were analyzing. And there's one more, piccolo occluder, which is dedicated for smaller patients. We can even use it for premature newborn, weighted 700 grams. But it has contraindications due to PDA diameters. PDA length can be smaller than 3 millimeters, and PDA narrowest diameter can be greater than 4 millimeter. So choosing the device for patients, we should be aware of those 3 contraindications, and also for the piccolo occluder worse outcomes in the group between 2 and 6 kilograms group of patients, comparing to group below 2 kilograms. And we analyze retrospectively 47 patients. I know it's not a great number of patients, but it's one of the largest parts of European database of the PDAs in that group of patients. And we analyze to check the effectiveness of the procedure, potential complications, and if it's possible to use off-label devices in patients with contraindications. The most common PDA type was type A. The female sex was more common, as we have expected. And what I want to underline, it's a burden group of patients with a high percentage of prematurity. 40% had comorbidities and 34% had perinatal complications. And some procedural parameters. Median age was 106 days. Median weight was 4.9 kilograms. And average patient had no contraindications for picola occluder, so this dedicated for that group of patients, with narrowest PDA narrowest diameter 2.4 millimeters and median PDA length 5.5 millimeters. 5 different types of devices were applied. Those 3 I've mentioned before, and in addition, in 4 patients there was a vascular plug, and in 1 patient there was coil implanted. And outcomes. The procedural success rate was at high level of 98%, with first attempt deployment in 91.6%. 5 patients needed reposition or device change. 3 patients had major complications, and those patients needed surgery. There were 2 residual shunts after 24 hours into patients, and there was 1 death which was not associated with the procedure. And to present and analyze the procedural problems. 1 procedural failed in picola occluder device that needed surgical closure. There was occlular embolization also in picola occluder that requires percutaneous removal. Femoral artery thrombosis also in picola occluder with unsuccessful thrombolysis. And the most severe complication, which was left pulmonary artery obstruction in vascular plug, and also it required surgery. All these patients requires device reposition or device change during the procedure. And off-label devices. 14 off-label devices were implanted, and we can divide them in 3 groups. 4 patients had applied devices not approved by FDA for the PDA closure. Those are vascular plugs, and in this group there was 1 patient with post-operative complications, 4 patients with PDA dimension contraindications, and 6 patients with weight under 6 kilogram contraindication. And the rest, 13 patients were free from post-operative complications. And comparing those 2 groups, labeled and off-label devices, prematurity was significantly more frequent in a labeled devices group, and narrowest diameter was significantly wider in off-label device group. But there was no significant difference in complications comparing those 2 groups. And in conclusion, PDA coexists with multiple comorbidities and perinatal complications. PDA transcatheter closure can be safely performed in neonates and infants under 6 kilograms with high procedural success rate. Off-label devices application is safe in selected patients with larger PDAs. And there was no difference in post-procedural complications between labeled and off-labeled devices. So we are still looking for a universal device in this group of patients, and hopefully in following years there will be one. And this is all I've prepared for today, and thank you for your attention.
Thank you for this pediatric approach, which was unique for our session. Do we have any questions from our scientific jury?
A very nice presentation, very nice work. published such data right now, or you are waiting for the patients or the follow-up?
It's an European initiative to collect data from all around all European countries to create a European database, and our data will be part of the European register, which will be published in probably next year. So
good luck.
Thank you.
Congratulations to you guys. Thank you for the presentation.
Thank you.
Now we are going back to Wrocław, and I invite Paulina Tomecka from the Institute of Heart Diseases, Wrocław Medical University, with the paper Transcatheter Aortic Valve Implantation, Short-Term Outcomes and Functional Improvements. Are you with us, Paulina?
Good morning. Yes.
Good morning.
Good morning. As the representation of Wrocław Medical University, we would like to present you the topic of transcatheter aortic valve implantation, short-term outcomes and functional improvement. To begin with, aortic stenosis is the abnormal narrowing of the aortic valve. It's the most frequent valvular heart disease in developed countries. Due to population aging, the number of patients is constantly growing. It's estimated that from the onset of symptoms, half of patients treated conservatively don't survive 2 years. TAVI is a recommended option for AS in older or high-risk patients. We retrospectively analyzed data on 354 consecutive patients who underwent TAVI at the Institute of Heart Disease in Wrocław between 2020 and 2022. Procedural aspects of TAVI and functional results were included in analysis. Baseline parameters were compared with a 3-month follow-up. A study group consisted of 190 females and 164 males. The mean age was approximately 79 years. The frequent occurrence of cardiovascular risk factors and comorbidities in patients, as well as the age, significantly influenced the clinical management. Of the entire group of patients, 26 had previously experienced a stroke, and 9 had an implantable cardioverter defibrillator. Additionally, 38 had previously experienced a stroke, and 153 were diagnosed with arterial hypertension. In order to assess the severity of aortic stenosis, echocardiography is required. Nearly a third of patients studied had an ejection fraction of less than 50%. The majority of TAVI procedure, that is 320, were performed via transfemoral vascular approach. The most prevalent types of valves were Edward Sapin and Medtronic core valve, used 193 and 105 times respectively. As demonstrated, the vast majority of procedures were performed under sedation. In comparison with open heart aortic valve surgery, the benefits of TAVI include a shorter hospitalization. The length of hospital stay for the majority of patients was from 3 to 4 days. The improvement in the general condition of patients undergoing TAVI procedure is a reduction in discomfort associated with heart failure symptoms. The New York Heart Association functional classification provides a simple way of classifying the extent of heart failure. Although we couldn't find every post-procedural outcome, we observed a significant NHA class improvement for both genders post-TAVI procedure as seen in the graph. Herein gender differences in NHA class are depicted. It's visible that women more frequently presented with NHA class 3 prior to TAVI, while men more often presented symptoms classified to NHA second class. The 6-minute walk test distance is a widely accepted measure of exercise capacity and functional status of the entire group. In 152 patients, it was possible to assess physical performance. Improvement in the exercise was observed in more than 80% of patients. We observed a difference in mean distance improvement according to gender. Although TAVI has a high successful rate, it still carries risks. In the perioperative period were observed 10 causes of stroke, 3 causes of acute coronary syndrome, and 39 causes of conduction disturbances requiring permanent cardiac pacing. I'd like to recap that TAVI in frail elderly patients is an efficient and relatively safe procedure. Patients experience functional improvement and a reduction of heart failure symptoms. That's all from our side. Thank you for your attention.
Thank you for the presentation, Paulina. And I believe now we can start our discussion. Do we have any questions from the scientific jury?
Nice presentation.
Thank you.
Very good results, and I don't have any question. Congratulations.
Thank you very much. It's a pleasure for us.
Very good results.
Thank you, Paulina. In that case, I believe we'll move on to our last presentation. Mrs. Alexandra Golec with the paper Balloon Aortic Valvuloplasty among patients with severe aortic valve stenosis. The floor is yours.
Dear attendees, it is my honor to present to you today the findings of our latest medical research on balloon aortic valvuloplasty among patients with severe aortic valve stenosis. Through tireless efforts, we have analyzed every aspect of the subject matter. We gathered some valuable data on efficacy of BAV procedure. Our data is the culmination of months of dedicated work by a team of skilled individuals. As you may know, AVS is a very common heart disease. Since it is almost as common as hypertension and ischemic heart disease, it definitely needs effective treatment methods. The one that we focus on was BAV. Now I will introduce you to the aim of our study, which was the evaluation of the effectiveness of the method. We analyzed 136 patients who underwent the procedure in First Department of Cardiology, Medical University of Silesia, between 2010 and 2022. As our primary endpoint, we assumed a reduction of mean pressure gradient less than or equal to 10 millimeters of mercury in transthoracic echocardiography. We excluded patients under 18 years old from the study. The table shows sex and age structure of our population. As you can see, about 73% of our population were at least 75 years old. Here you can see some symptoms that the patients suffered from, such as dyspnea, peripheral edema, and syncope. Most of patients had accompanying diseases. Over 60% of patients had hypertension. Moreover, chronic kidney disease, diabetes type 2, and coronary artery disease were common in our population. The population was characterized by mean Euroscore 2 equaling 9.07 and median NYHA class 4. Almost 50% suffered from reduced left ventricular ejection fraction. Left ventricular hypertrophy occurred in 21 cases. A mean of aortic valve area is 0.68 square centimeters. A mean of mean pressure gradient is 45.1 millimeters of mercury. Only 5 patients had bicuspid aortic valve. Percutaneous coronary intervention was needed 16 times, mostly before BAV. In the slide, you can see that the BAV was used as a preliminary method to enable other medical procedures, such as TAVI or AVR. BAV was performed as a bridge therapy to TAVI in almost 70% of cases, although we cannot overlook the fact that in a quarter of cases, BAV was performed as a palliative procedure. The reduction of mean pressure gradient less than or equal to 10 millimeters of mercury was achieved in more than 50% of the population. 2/3 of them were women. Patients with successful BAV had lower heart rate, lower aortic valve insufficiency jet, but greater initial mean pressure gradient. Moreover, they had low gradient AVS less frequently. Among 19 deaths, in general, 11 patients died in less than a year. All of them had accompanying diseases. Over 50% of patients who died in hospital had diabetes type 2. 2/3 of those patients who died had to be intubated or ventilated mechanically. In 12 out of 13 patients with low gradient AVS, BAV was unsuccessful. P-value equals 0.001. As you can see, BAV procedure affects in a significant decrease of mean pressure gradient as well as maximum pressure gradient. In conclusion, BAV is an effective method with an acceptable rate of adverse events. However, it should be considered as a temporary solution. High-risk patients with AVS, especially ones with severe low gradient AVS, should be referred for prompt destination therapy, including TAVI. We hope that findings we obtain somehow will contribute to medical advancement in the future. Thank you for your attention, and if you have any question, I would be more than happy to answer them.
Thank you for the presentation. Do we have any questions from our scientific jury?
Yeah, I'd like to congratulate you on this analysis. It's a delicate topic. Treated like a palliative treatment, the bowel angioplasty. Recently, it gains the indications for bridge treatment, and maybe you know what was the correlation between those unsuccessful procedures and the bridge therapy to other interventions, like to TAVI to surgical replacement. I mean, if in the lack of success was the indication for further treatment, or it was not correlated.
Well, we didn't actually gather such data, so I can't answer this question by the data we have gathered.
Okay, thank you.
I have got one question. What was the rate of the vascular access complications during the during the BAC procedure? Do you have such data? Vascular complications. I mean the access complications during the procedure.
I'm sorry, did you...
One of the most frequent complications during those procedures is the access complications in the femoral artery. And do you have such data? How often was the vascular access complication?
Well, we don't have knowledge about complication in our group of patients.
All right. Thanks.
Thank you for this discussion. Do we have any more questions, or should we? So, thank you for your presentation. All of the submitted papers have been presented. Oh, sorry, I guess we have an issue. It should be all well now. All of the submitted papers have been presented. We congratulate all of the authors and participants of our session. We hope that you enjoyed the time and the exchange of views and observations will contribute to increase of your medical knowledge. At this point, I would like to kindly ask the honorary member of the jury, Professor Deszczęca, for a few words to sum up the session.
Yeah, really compliments to all those who presented the abstract. I realize the high level of quality of this presentation, the research on the clinical issues under this presentation. So compliments, and I will immediately grade the abstract. Compliment, thanks for the invitation.
Professor
all of those presentations were in high level, and I would like to thank you, Professor Deszczęca, that you were with us, and hope so in the future you will be also attend to our students' Silesian conference. Thank you.
Professor Deszczęca, it is an incredible privilege for us to host you here today as the honorary member of our jury, and this is truly a unique opportunity for us to present our research in front of such an accomplished professor. Oh?
Yeah, thank you very much.
You're most definitely an inspiration for all of us, and I believe your comments and thoughts will guide the route for our students for their further research. So now let me express the thanks for all of the members of the esteemed jury. We truly appreciate all of your valuable comments and accurate observations. And dear participants, I would like to cordially invite you for the decoration and closing ceremony of the SIMC 2023 conference on the Friday, 19th of May at 4:15. And ladies and gentlemen, I believe the session of invasive cardiology and cardiothoracic surgery is officially closed. Thank you for your attention and for joining us here today. Thank you.
Thank you.
Thank you very much.